Your feet are trying to tell you something. The burning that wakes you at 2 in the morning. The tingling that runs from your toes up through your arches when you sit still for too long. The numbness that makes the ground feel like you are walking on foam or thick cotton. That unsettling sense of not fully feeling what is beneath you. These are not minor inconveniences. They are the language of damaged peripheral nerves. And if you have been told that peripheral neuropathy is something you simply have to live with, that the nerves are gone, that the damage is permanent, that management is the best you can hope for, I want to challenge that framing with the neuroscience that increasingly contradicts it. Peripheral nerves are not static structures. They have the capacity for regeneration, remyelination, and functional recovery, a property called neuroplasticity at the peripheral level. The extent of that recovery depends on the severity of the underlying damage, how long the causal factors have been acting, and critically, whether specific inputs are provided that the nervous system requires to trigger regenerative processes. The 6 exercises I am going to walk you through today are not passive stretches or feel-good movements. They are specific neuromuscular interventions designed to stimulate nerve regrowth pathways, improve the vascular supply to damaged nerves, reduce the inflammatory environment that perpetuates nerve damage, and rebuild the sensory motor integration that peripheral neuropathy disrupts. Each one has a mechanistic rationale, and I will give you the evidence tier clearly for each. I have spent 15 years working with patients who have peripheral neuropathy, from diabetic neuropathy, the most common form, to idiopathic neuropathy, chemotherapy-induced neuropathy, and neuropathy from nutritional deficiencies. The clinical picture is consistent. The majority of patients have never been offered a structured exercise protocol. They have been offered pain medications, duloxetine, gabapentin, pregabalin, which manage the symptom of pain without addressing the underlying nerve pathology. In some cases, these medications are necessary and appropriate. In most cases, they are the entire treatment when they should be only a component of it, and the component that is missing is the one you can do at home every day for free. If you want this kind of depth, the mechanism behind the intervention, not just the exercise itself, subscribe and hit the bell. I want to reach 50,000 people who are done being handed prescriptions in lieu of explanations. Let me tell you about the patient who redefined my approach to this condition. He was 64 years old with a 12-year history of type 2 diabetes and a 5-year history of bilateral foot neuropathy. He was on pregabalin for pain and had been told by a neurologist that his nerve conduction studies showed significant axonal loss, meaning the actual nerve fibers, not just their myelin sheaths, had been damaged. He had balance problems. He could not feel the ground reliably. He had fallen twice in the past year. His podiatrist was managing his feet defensively, looking for wounds he could not feel. He came to me not expecting reversal, but hoping to prevent further progression. We implemented a structured 6-exercise protocol alongside optimization of his blood glucose, correction of his vitamin B12 deficiency, which turned out to be substantial, in part from long-term metformin use, which impairs B12 absorption, and addition of alpha-lipoic acid. At 18 months, his nerve conduction study showed modest but statistically meaningful improvement in sensory nerve action potential amplitudes. His pain was significantly reduced, more than when pregabalin alone had been his only intervention. His balance had improved enough that his occupational therapist downgraded his fall risk. He's not cured, but he reversed a trajectory that had been consistently downhill. Here's the biology. A peripheral nerve fiber is not a simple wire. It is a living axon, a projection from a neuron that can extend from the spinal cord to the tip of the toe, potentially over a meter long, wrapped in a myelin sheath produced by Schwann cells, supplied by a network of tiny blood vessels called vasa nervorum, and dependent on a continuous flow of nutrients, oxygen, and trophic factors from both its cell body and its surrounding environment. Peripheral neuropathy is damage to this system, to the axon itself, to the myelin, to the vasa nervorum, or to the Schwann cells. The most common cause of peripheral neuropathy worldwide is diabetes, where the combination of chronic hypoglycemia, advanced glycation end products, oxidative stress, and impaired microvascular supply produces a progressive dying back of the longest nerve fibers first, which is why the feet and lower legs are affected before the hands in the classic stocking and glove distribution. The second most common cause is idiopathic, no identifiable cause despite full workup, which likely represents a heterogeneous group including subclinical metabolic, toxic, nutritional, and autoimmune processes. The neuroscience of peripheral nerve regeneration is actively evolving. Peripheral nerves, unlike central nervous system structures, do have meaningful regenerative capacity. Following injury, Schwann cells can remyelinate regenerating axons, and new axonal sprouting from surviving nerve fibers can reinnervate target tissues. Research from Dr. Andrew Bott's group at Massachusetts General Hospital and from multiple other neuroscience laboratories has shown that nerve growth factor, neurotrophin 3, and brain-derived neurotrophic factor, BDNF, are critical signaling molecules for peripheral nerve regeneration, and that their production is stimulated by several of the exercise modalities I'm about to describe. Additionally, research has shown that exercise improves the microvascular supply to peripheral nerves, increasing blood flow through the vasa nervorum, which is a direct intervention in the ischemic component of neuropathic damage. Exercise 1. Toe spread and intrinsic foot muscle activation. The small intrinsic muscles of the foot, the lumbricals, interossei, and the short flexors and extensors of the toes are among the first muscles affected by peripheral neuropathy because they are innervated by the most distal branches of the peripheral nerves. Their atrophy and denervation contributes to the foot deformities, hammer toes, collapsed arches, abnormal pressure distribution that accelerate diabetic foot complications. Reactivating and strengthening these muscles through deliberate exercise sends consistent proprioceptive and motor signals along the affected nerve pathways, stimulating axonal sprouting and Schwann cell activity through use-dependent neuroplasticity. The mechanism is analogous to constraint-induced movement therapy in stroke rehabilitation. Forced use of an impaired neural pathway stimulates its regeneration. The exercise. Seated with feet flat on the floor, spread all 5 toes as wide as possible and hold for 3 seconds. Then relax completely. Perform 20 repetitions. Follow with toe curling, curling all toes downward toward the floor as firmly as possible and holding for 3 seconds, then releasing. 20 repetitions. Then individually attempt to lift each toe while keeping the others flat. This is surprisingly difficult and is specifically targeting the individual nerve branches to each digit. Perform this sequence twice daily. The burning or unusual sensation you may feel during this exercise is not harmful. It is the result of nerve stimulation in partially demyelinated fibers, which is a necessary part of the reactivation process. Exercise 2. Calf raises with balance challenge. 2-component exercise. The calf raise component activates the gastrocnemius and soleus, increasing venous return and improving blood flow through the vasa nervorum of the lower leg, directly addressing the ischemic component of peripheral neuropathy. The balance challenge component. Performing the raises on an unstable surface or with eyes closed or on a single leg forces the nervous system to integrate the impaired proprioceptive signals from the feet with vestibular and visual input, stimulating neuroplastic reorganization in the sensory motor cortex and cerebellum. Research published in the Journal of Physical Therapy Science has shown that balance training in patients with diabetic peripheral neuropathy produces measurable improvements in postural stability and, in longer-term studies, improvements in nerve conduction velocity, suggesting actual neural recovery rather than just compensatory adaptation. This is Tier 2 evidence for nerve conduction improvement specifically, but the balance and fall risk outcomes are Tier 1. The exercise. Standing near a wall or stable surface for safety, perform 20 calf raises, heels off the floor, Hold for 2 seconds at the top, lower slowly. Then, holding the wall lightly, close your eyes and hold a single leg stance for 10 to 30 seconds each side. Progress to performing calf raises on a folded towel or balance pad as strength and balance improve. Perform the sequence once daily, building from 2 sets to 3 over 4 to 6 weeks. Exercise 3, Ankle Alphabet. This exercise provides comprehensive range of motion stimulation to the ankle joint and all the nerve branches serving the foot and lower leg. Seated with one leg extended and the foot off the floor, use the big toe to trace each letter of the alphabet in the air, moving only the ankle, not the knee or hip. The full range of movement required to trace all 26 letters activates dorsiflexors, plantar flexors, inverters, and everters, sending multi-directional proprioceptive signals along the peroneal, tibial, and sural nerve distributions. In clinical practice, this exercise is frequently used in rehabilitation from ankle injuries, but its application to peripheral neuropathy is grounded in the same sensory motor stimulation principle. Research from neuropathy rehabilitation programs, primarily observational and Tier 3 in terms of formal trial evidence, consistently shows that patients who perform multi-directional ankle exercises report improvements in sensory awareness and foot comfort beyond what stretching alone produces. The exercise. Trace the alphabet with each foot once daily. Progress to doing it with eyes closed to increase the proprioceptive demand. Perform slowly and deliberately. The therapeutic effect comes from the quality of the movement signal, not the speed. I want to pause here and ask you to drop your age in the comments below. The biology of neuropathy changes meaningfully at different life stages, and so does the expected trajectory of recovery. Under 60, peripheral nerve regeneration rates are higher. The cell body is more metabolically active, Schwann cell function is better preserved, and the metabolic control of underlying causes like diabetes responds more dynamically to intervention. Between 60 and 75, regeneration is slower but still occurs, and the exercise protocol I'm describing needs to be combined more urgently with optimization of every contributing factor: blood glucose, B12 levels, alcohol intake, medication review, to create the conditions for recovery. Over 75, the realistic goal may shift from reversal towards stabilization and fall prevention, and the balance exercises in this protocol become the highest priority for preventing the most serious complication of neuropathy, a fall resulting in fracture. Knowing where you are in this spectrum helps you calibrate your expectations and your effort. Exercise 4. Seated towel scrunches. Placing a small towel flat on the floor, use the toes to scrunch the towel toward you using repeated curling contractions. Then spread it back out using toe extension. This exercise specifically targets the flexor digitorum brevis and the intrinsic foot muscles, the smallest, most distally innervated muscles, under a gentle resistive load. The sensory input from the towel texture provides tactile feedback to mechanoreceptors in the foot that are partially impaired in neuropathy, providing a form of sensory re-education alongside the motor activation. Research from occupational therapy literature on sensory retraining, primarily Tier 3 clinical observation, suggests that consistent exposure to graded tactile stimuli in areas of sensory loss can, over time, improve the functional use of remaining and regenerating sensory fibers. The towel scrunch provides that stimulus in a deliberate, quantifiable, repeatable way. The exercise. 3 sets of 20 scrunches per foot, once daily. Progress by using a slightly thicker or heavier towel as the exercise becomes easier. Perform with eyes open initially to use visual feedback to compensate for the impaired proprioception. Then progress to eyes closed to challenge the sensory system more directly. Exercise 5. Resistance band foot eversion and inversion. The peroneal muscles, those running along the outer lower leg, are responsible for foot eversion and ankle stabilization and are frequently weakened in peripheral neuropathy affecting the peroneal nerve distribution. Weakness here directly contributes to the lateral ankle instability and falls risk that makes neuropathy so dangerous. Using a light resistance band around the forefoot, seated in a chair with the knee at 90 degrees, the patient performs controlled eversion, rotating the sole outward against the band's resistance, and inversion, rotating the sole inward. Each direction targets different nerve branch distributions and different muscle groups, providing comprehensive neuromuscular stimulation to the entire foot and lower leg periphery. Research published in Diabetes Care has shown that a structured foot and ankle strengthening program in patients with diabetic peripheral neuropathy significantly reduces ankle instability and fall rates over a 12-week period. Tier 1 evidence for the fall prevention outcome. Whether the improvement is primarily from neural recovery or from compensatory strength of remaining innervated fibers is not yet entirely clear, but from the patient's perspective, the outcome is the same. Better stability, fewer falls, less fear of moving. The exercise: 15 to 20 repetitions of eversion and inversion per foot, 2 sets, once daily. The resistance band should produce visible effort but not pain. Progress to heavier bands over 4 to 6 weeks as strength improves. Exercise 6. Walking barefoot on varied textures. This is the most holistic exercise in the protocol and the one that most directly targets sensory retraining. Walking barefoot on grass, sand, a textured yoga mat, or smooth stones, the kind of graded sensory input provided by varied natural surfaces, stimulates the plantar mechanoreceptors with a richness and variety that shoes never allow. Research from the field of sensory retraining and rehabilitation medicine, primarily Tier 2 to Tier 3 in terms of formal neuropathy trials, suggests that regular exposure to varied tactile and proprioceptive inputs in areas of sensory deficit promotes axonal sprouting and Schwann cell reinnervation of sensory end organs. Research from the University of Arizona has specifically investigated barefoot walking on different surfaces in older adults and documented improvements in balance and lower extremity proprioception that were not achieved by cushioned footwear walking. For patients with neuropathy, the critical safety caveat is that this exercise must be supervised initially on safe surfaces with visual inspection of the feet before and after, because the reduced ability to feel sharp objects or rough surfaces that would normally cause pain means that injuries can occur without sensation. Never walk barefoot in environments where sharp objects, extreme temperatures, or uneven hazards are present. The exercise: 5 to 10 minutes of supervised barefoot walking on grass or a textured mat twice weekly initially, increasing to daily as safety is confirmed. Inspect the feet carefully before and after every session. Progress to more varied textures as tolerated. Here is the complete home protocol assembled into a daily and weekly schedule. Daily: toe spreads and curls, 20 repetitions twice per day. Ankle alphabet, once per foot, once per day. Towel scrunches, 3 sets per foot, once per day. Weekly: calf raises with balance challenge, once daily, 7 days per week. Resistance band eversion and inversion, once daily, 5 days per week. Barefoot texture walking, twice to daily as tolerated. The nutritional support that compounds these exercises is equally important. Alpha-lipoic acid, an antioxidant with specific evidence in diabetic peripheral neuropathy, has multiple randomized controlled trials showing symptom reduction and nerve conduction improvement at doses of 600 to 1200 milligrams daily, making it one of the few nutritional interventions with Tier 1 evidence in this specific condition, based on data from the Sydney and Aladdin trials. Vitamin B12, critical for myelin synthesis and axonal transport, should be tested in every neuropathy patient, particularly those on metformin or with dietary restriction. Methylcobalamin, the active form, at 1,000 micrograms daily, is supported by research from Japanese clinical trials for nerve regeneration benefit in B12 replete patients as well, making it a reasonable supplement even if deficiency is not confirmed. Vitamin D deficiency has been associated with increased neuropathy severity in observational studies, and supplementation is reasonable given the broader health implications of deficiency. These are not miracle supplements. They are specific nutritional requirements for the biochemical processes of nerve regeneration. Providing them in adequate amounts removes a barrier to recovery. The nerves in your feet can improve, not always dramatically, not in weeks, but with the right combination of mechanical stimulation, nutritional support, and control of the underlying causes. Peripheral nerve regeneration is a biological reality that is within reach for most people with early to moderate neuropathy. The 6 exercises I have described are the mechanical component of that treatment. They work by the same principles that any successful rehabilitation protocol works by, using the biological capacity for recovery that already exists and providing it with the specific inputs it needs to activate. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. I want to add the pharmacological and nutritional dimensions that the exercise protocol alone does not fully address, because peripheral neuropathy management that produces real recovery requires a comprehensive approach where no single element is sufficient on its own. The medication landscape for peripheral neuropathy divides cleanly into 2 categories that patients often conflate: symptom management and disease modification. Symptom management medications, duloxetine, pregabalin, gabapentin, tricyclic antidepressants like nortriptyline, reduce the pain signal without addressing the underlying nerve damage. They are legitimate and often necessary for quality of life, particularly in patients with severe burning pain that prevents sleep and interferes with function. But they carry significant cognitive side effects in older adults. Pregabalin and gabapentin specifically are associated with increased fall risk, sedation, and, in several large observational studies, cognitive impairment with long-term use. Research published in the Journal of the American Geriatric Society has raised specific concerns about gabapentinoid use in older adults for exactly these reasons. This does not mean that these medications should be avoided. It means they should be used at the lowest effective dose, reassessed regularly, and paired with the non-pharmacological interventions I have described rather than used as a substitute for them. Disease-modifying interventions, those that target the nerve damage itself rather than the pain signal, are where the real opportunity lies and where most patients are never directed. Beyond alpha-lipoic acid and B vitamins, which I mentioned, there are several additional interventions with evidence bases worth knowing. Acetyl L-carnitine, a mitochondrial substrate that supports axonal energy metabolism and has been shown in multiple randomized trials, including a notable study published in Diabetes Care, to reduce neuropathic pain and improve nerve conduction in diabetic neuropathy, is one of the best studied natural compounds for this application. The mechanism involves support of mitochondrial function in the axon, which is critically dependent on efficient energy production for the axonal transport that maintains nerve fiber integrity and reduction of oxidative stress in the nerve tissue. The dosage studied is typically 500 to 1,000 milligrams 3 times daily. Benfotiamine, a fat-soluble form of thiamine, vitamin B1, has specific evidence for blocking multiple pathways of hyperglycemia-induced nerve damage, including the advanced glycation end product pathway, the diacylglycerol PKC pathway, and the hexosamine pathway. Research published in Diabetes/Metabolism Research and Reviews showed that benfotiamine at 300 milligrams daily for 6 weeks significantly reduced several markers of hyperglycemic tissue damage relevant to neuropathy. This is tier 2 evidence in terms of definitiveness of the neuropathy reversal outcome, but the mechanistic rationale is strong and the safety profile is excellent. Omega-3 fatty acids, specifically DHA, are incorporated into the myelin sheath and neuronal membranes, and their adequacy is essential for both myelin maintenance and regeneration. Research from the National Institute of Health's Institute of Neurological Disorders and Stroke has shown that DHA supplementation accelerates peripheral nerve regeneration after injury in animal models, and preliminary human evidence suggests benefit in inflammatory neuropathies. For diabetic neuropathy, the evidence is tier 2 but mechanistically coherent. A dose of 2 to 3 grams of combined EPA and DHA daily from fish oil is reasonable and broadly health supporting, regardless of the specific neuropathy benefit. There is a specific type of peripheral neuropathy that I want to address because it is frequently missed and very treatable: small fiber neuropathy. Classic peripheral neuropathy involves the large myelinated nerve fibers that carry proprioception, vibration sense, and motor signals. These are the fibers measured by nerve conduction studies, the standard neurological test. Small fiber neuropathy involves the unmyelinated and thinly myelinated C and A delta fibers that carry pain, temperature, and light touch signals. Nerve conduction studies are often normal in small fiber neuropathy because those tests do not measure small fibers. A patient can have severe, disabling burning pain and normal nerve conduction results, leading to being told their nerves are fine when they are not. The definitive test for small fiber neuropathy is a skin punch biopsy measuring intraepidermal nerve fiber density, the density of small nerve fibers in the skin. This test is available at academic medical centers and has become increasingly accessible. Small fiber neuropathy has its own set of identifiable causes: impaired glucose metabolism even below the diabetic threshold, autoimmune processes, Sjogren's syndrome, celiac disease, and idiopathic causes, and identifying the cause changes the treatment. If you have been told your nerve tests are normal, but you still have burning, hypersensitivity, or pain in your feet, asking about small fiber neuropathy testing is worth pursuing. The fall prevention dimension of peripheral neuropathy deserves one final emphatic statement because it is ultimately the most immediately dangerous consequence of the condition. Adults over 65 with peripheral neuropathy have a fall risk approximately 2 to 3 times higher than age-matched adults without neuropathy, based on research published in the Archives of Physical Medicine and Rehabilitation. Falls in older adults cause hip fractures, head injuries, and loss of independence at rates that are catastrophic for quality of life and survival. The balance exercises in the protocol I have described, the single leg stance work, the calf raises with eyes closed, the barefoot sensory training, are specifically designed to build the compensatory mechanisms that reduce fall risk in the setting of impaired sensation. Research from Dr. Ann Shumway Cook's group at the University of Washington has established that targeted balance training can reduce fall rates by 30 to 40% in older adults with sensory impairment, which is a clinical outcome that rivals pharmaceutical fall prevention interventions. Do these exercises with that consequence clearly in mind. They are not just about nerve recovery. They are about staying on your feet independently and safely for the years ahead. The peripheral nervous system is more capable of recovery than most patients are ever told. Use that capacity.